My name is Rudi. It's originally in Croatian pronounced Hrncic, which is a tough one, I guess. And it's spelled Hrncic. So many people ask me, is this really a mistake? And I'm trying to tell them that I wasn't on the Wheel of Fortune. So I wasn't able to purchase the letters to put them in between, right? So anyway, I want to tell you, because so many of you are first time here, I want to tell you a little bit of story. It's a little bit about me, about my background, and essentially about relationship between me and this great institution called IMF, right? In 1994, I joined the Department of Human Immunology in Knoxville, Tennessee. And my mentor at that time, Professor Alan Solomon, was very interested in two topics, myeloma and amyloidosis. And guess what? You know, that's how it started. A few years after, under his mentorship, I was able, essentially in the year 99, get a junior grant from International Myeloma Foundation, and I got 3 in the row. And I'm very grateful. I'm very, very grateful because my career wouldn't be what it is today without the help from people from IMF. Why is this important? In year 2000, topic on my research was amyloidosis, light chain amyloid, right? It can be complication of myeloma. It could be separate identity, separate disease, right? What is interesting about it is that it is also monoclonal gammopathy. It also starts in the bone marrow, etc. So, in year 2000, I published something in American Journal of Pathology with my colleagues and my mentor. NIH, a few years later, modified this particular antibody. And I'm very pleased to tell you, my friend, that last December at ASH, American Society of Hematology, Dr. Suzanne Lange was using this particular antibody, and they have very good results in the patient with amyloid. So another great win for the patient, everybody else. And I have to say, without IMF, that wouldn't be possible. So, okay, talking about the lecture. So today we're going to talk about serum-free light chain assay, most of the time. So we have so many different biomarkers, right? Only good thing about myeloma is that those cells in the bone marrow, they can produce a little bit of specific proteins and release them in circulation. If we take a little piece of serum, we can measure amount of the protein present, and usually based on that, we can calculate that, because usually it's a good indicator, you know, how much protein and what is the activity in the bone marrow. Usually, it does work very well. So we can measure several different biomarkers, and we use several different methods, right? We could use electrophoresis, we could use immunofixation, and we're measuring as well serum-free light chain. Look, it's self-explanatory, right? Serum, right? It's free light chain. So we are obtaining serum sample, like first, right? It's called free because light chains are coming in 2 forms, as a free light chains and the light chains that together with heavy chain making intact immunoglobulin molecule or antibody, right? So 80% of those approximately are part of intact immunoglobulin molecule. Those 20-30% eventually that are not part, because they are not part of intact immunoglobulin molecule, they are called free light chains, and we are measuring them. So all those proteins, they start right in the bone marrow, and that's why we can measure them, right? Let me tell you a little bit about the B cells, right? Under normal circumstances, we all have those cells, right? You, me. Those cells are like little factories. They produce antibodies. And in the case of infection, right, those antibodies go sky high, right, in concentration because they are fighting infections. And we produce many, many different antibodies. And as I said a few minutes ago, antibody has 2 major components, heavy chain and light chain. But using the serum-free light chain assay, we are measuring just those free light chains that are not part of molecule. Okay, when infection gets cleared, what happens? Concentration drops down, right, to the normal level. That's why we have normal reference range. Okay, so myeloma is a cancer of plasma cells. Unfortunately, myeloma picks one of those B cells, right? And it's making a lot of antibodies. That precisely, that cell replicates, but it's making many, many copies. The only problem with those copies are they are non-functional one. They produce protein that is non-functional. Only good thing about it is what? We can measure it. And usually, by measuring those proteins, we are able to establish the relationship. Usually, they are good biomarker of activity in the bone marrow. So, plasma cells, they secrete intact antibody, right? Whole antibody. And they produce free light chains. Mayo Clinic established normal reference range for the free light chain in healthy non-myeloma disease population by choosing people from 18 years of age up to 90-something, right? So we all have light chains during lifetime. Just in the case of myeloma, those B cells, myeloma cells, they replicate, and since there is so many of them, they start releasing light chains in the circulation. If we take a little serum sample, right, we can measure it. So according to, we have different type of myelomas, right, based on what they produce. Myeloma can produce just intact immunoglobulin, can produce just light chains, that's why it's called light chain myeloma, or can, on average, they usually produce mixture of both. So many times you heard the question, so you are what, IgG, you have IgG kappa myeloma, right? It's based on the type of immunoglobulin that myeloma picked, right? It could be IgG, it could be IgA, for example, right? And then it could be kappa or lambda, because that particular cell myeloma picked was IgG kappa, right? And it's predominantly producing IgG kappa. For example, so what we are measuring are not those antibodies. If you see that form shaped like letter Y, that the dark part, long one, would be heavy chain. And those two little like wings on the side, those are the light chains. But as I said, those are serum-free light chain, does not measure light chains that are part of intact immunoglobulin molecule. Serum-free light chain assay measures only what? Free light chains, the ones that are not part of intact immunoglobulin molecule. So, what is happening? Myeloma picks one of those cells. It could be IgG kappa, it could be IgG lambda, IgA, kappa lambda, etc. But usually, first time by detecting that abnormal protein in the serum, we can tell something is going on in the bone marrow. It doesn't immediately tell you you have or somebody has myeloma, right? It could be any type of B cell abnormality that is producing abnormally high concentration, right? It could be other type, it could be MGUS, it could be smoldering myeloma, etc. So myeloma is cancer, obviously, of the blood and bone marrow, right? So what is the major culprit for myeloma? Producing intact antibody, free light chain, as I said, or both. Some patients have anemia. A lot of people have bone, and I probably heard it in the great previous presentation more about it. I remember what Dr. Kyle used to say about it. Myeloma is a very peculiar disease. It almost can mimic many other diseases. Because when you think like bone pain is most prominent one. Yes, but even the people that are not myeloma disease people have a lot of back pain or bone pain, right? So we have to concentrate on biomarkers that we can identify in order if we decide to screen for disease or we decide to detect it early. Okay. As I said, bone pain is most prominent one, the repeat one that lasts for months and months and months. Culprit, again, of myeloma is overproduction of one single specific protein. That's the only good thing about myeloma, because when in serum, we can measure that protein, and usually it tells us pretty good what is the level of activity in the bone marrow. how we can, when you take the blood sample, as you know, it's like a cocktail of many, many different things. There are cells, chemicals, a lot of different things, right? So you have to separate, it's not that easy to measure. It's like, if you think about it, when you make a bouillon or soup, right? You put like a chicken, you put a carrot, you put everything, a lot of different stuff. But it would be very tough to separate those things again if you want to put them in their primary state, right? So we have, thank goodness, methods how to separate those proteins. What we are using electrical current, essentially. So we are putting the serum sample in the specific gels. And when you turn on the electricity essentially the field separates them. Okay, think about it. If you are on the bridge in Gatlinburg, Tennessee, above Beautiful Creek, and you drop a couple of pieces, like, you make a paper boats, and you throw all of them at the same point, at the same time. But if they are heavier or smaller, depending on the size, the same current is going to separate them, right? You see what I'm trying to say? So in the same fashion, this electricity, that particular current, is separating everything what came in that particular sample. On the right side of the slide, you can see, on the left side, you see that in the particular, on the region, on the right side, you see that sharp peak. And this is typical, like, myeloma peak. Especially, it's like textbook thing. Usually it appears in the gamma region, right? But not always. This is, as I said, textbook. And that way, doctor can know, okay, something is going on, but you don't know what type of myeloma it is, or it is myeloma, is something different. Usually it is. But you have to do the bone marrow, you have to do other additional studies as well, right? This is just one of the biomarkers. Dr. O'Neill from Emory once gave a very nice example. Dr. O'Neill said, many instruments you have in the plane, right? More you have, better off you are, because you can control so many different things, right? If you concentrate just on one instrument, that wouldn't be good when flying. So it's monitoring myeloma. We have many different tools. And as I pointed out, serum electrophoresis is one of the great tools that physicians have to measure those monoclonal proteins that myeloma is making, and that way we can control and observe activity of disease itself. Myeloma could produce, right, again, intact immunoglobulins and light chains. So we have different methods to measure those biomarkers. In the green circles, you would see just a little light chains. In the blue one, you would see intact immunoglobulin molecules. So again, I'm just going to remind you. So this particular method, serum-free light chain assay, is not measuring any of the intact immunoglobulins. It's measuring free light chains. Mayo Clinic, as I said, established normal reference range for the light chains in the healthy populations. And here we have, normal reference range for kappa is 3.3 to 19.4 milligrams per liter, while lambda is 5.7 to 26.3. If you think about the numbers, they are pretty close, right? They're pretty close. So this is probably the most important thing for you to take home as a message, okay? In the case of infection, both of light chains would go up, right? In the case of renal disease, in case of inflammation, autoimmune diseases, right? Both of them. But they go both, let's say, from 5 mg to 30, 40, but they are kind of at the same level. What we said about myeloma would usually pick one of those, right? Kappa goes to 100, and lambda remains 5, right? Under normal circumstances, what was the novelty about serum-free light chain assay? We are measuring, this is very important, we are measuring 2 things, kappa and lambda light chains. A little bit of history. Why they call them kappa and lambda? Because two scientists that discovered them, their names started with K and L. So, oh, really? And so, in the case of myeloma, myeloma picks one of them. When serum free light chain was introduced as assay, we introduced something what is called kappa to lambda ratio. Never other way around. It's always kappa to lambda, right? And I will give you examples later on. So what we learned today is we are measuring serum-free light chains. They're kappa or lambda, right? Here's normal reference range. In the case of myeloma, one of them goes up. And if kappa goes to 100 and lambda stay 5, right? You divide 100 by 5, and you get ratio of approximately 20, right? And if you see normal, in the healthy individuals, no myeloma disease population, you would have ratio of 0.26 to 165. So if you divide 100 by 5 and you get 20, you have highly abnormal ratio. It means that one of the light chains is abnormally high. Is that clear? So we are measuring two things, kappa light chains, lambda light chains. We are always reporting it, and everybody in your laboratories, your doctors, kappa to lambda ratio. So everything then above 0.65, 165, 0.2, and everything below 0.26 means something is going on. If somebody has little abnormality in the ratio, it doesn't mean that somebody has myeloma. It's just a biomarker. It could be MGAS, okay? I'm going to just make something clear. Do we have any questions on serum-free light chain assay? Yes?
Can you explain what's happening non-secretory?
You're saying non-secretory? Oh, okay. Well, that's a great question. Question a gentleman asked, non-secretory myeloma, right? Okay. Let me tell you a little bit of history. Obviously, I like to talk about the history, right? So, we used to call them non-secreting myelomas or pseudo-secreting myelomas because 20 years ago, we didn't have tests sensitive enough to pick low concentrations, right? Great advantage of serum-free light chain assay, and this is a great question, is because before we promoted serum-free light chain assay as a new assay to analyzing some of those biomarkers like light chains, right? We didn't have sensitive tests. That's why if you used electrophoresis or even immunofixation, we would miss those patients. And serum-free light chain assay is picking them. Why? Because you need at least a couple of hundred mix before serum electrophoresis is going to pick that. You're going to see that peak that I showed you a couple of slides ago, right? Serum immunofixation is 50 to 100 something mix. So if it's below that, it won't pick it up. When we are talking about the light chains. And I showed you in the, serum-free light chain picks them at very low level. That's why we are able to establish normal reference range of just 5, right? Why is this important? It is important because in the recently published clinical studies, by using serum-free light chain assay, they are able to pick almost 80% of those non-secreting. So we're going to still have really non-secreting myelomas, right? Those are that do not produce anything, right? But now, by introducing serum-free light chain assay, historically, in comparison, we are able to pick 80% of them now. That's a great question. Because, if you couldn't measure that, patients would show up to physician maybe with extreme bone lesions because they wouldn't be able to pick anything in their serum sample. Okay. So, again, I just want to confirm one more time. Serum-free light chain assay. We pick a little serum sample. We are measuring light chains. They're called free light chains because they are not part of intact molecule, right? We are measuring two kappa and lambda light chains. And we are reporting a ratio, always kappa to lambda. Abnormality in the ratio usually means that something is going on in the bone marrow. But also, okay, we are measuring kappa and lambda. Remember my 100, kappa of 100, lambda of 5, you divide them, abnormality of the ratio 20, right? Then you give chemotherapy to this hypothetical patient. That concentration goes from 100 back to normal. Then that's what we call response to therapy, right? That's how doctors are using these biomarkers, not just to detect the disease first time, but by measuring serum free light chain. And usually they don't make decisions based just on one measurement, right? Usually it's trend of change when they are looking like M spike is going down, serum free light chains are going down. And then when we say patient is in complete stringent response, it means that serum free light chain is normalized, that serum and urine immunofixation are negative, right? I want to tell you very, very briefly about the new test just came recently. It's called Hevylite. When we talked about, please don't get confused. All I want to tell you, if you remember today, when you go home, that serum free light chain, assay was measuring serum sample, it was measuring kappa and lambda, and the ratio, you're good to go, right? So I'm just really, when we're talking about Hevylite is obviously measuring something different. This is the molecule, intact immunoglobulin molecule, antibody. The blue is the heavy chain. The red are the light chains, like little wings on the side. Okay, so serum free light chain is totally different test than Hevylite because Hevylite is measuring totally different. Hevylite is now measuring that intact immunoglobulin molecule. Okay? And gives you kappa and the lambda part as well, because the blue part of the molecule, the big Y-shaped blue part of intact immunoglobulin, will tell you a little bit more what kind of, it will determine if that antibody or immunoglobulin is G or A or M, etc. But those little red wings gonna tell if it's kappa or lambda. And as far, this is kind of like very over-engineered assay in the terms, because it's very complex to produce. And it's good because it gives us additional tool that measures something that we were not able to measure before. And what I want you to remember is myeloma gonna pick one of those cells, right? Let's say, again, IgG, hypothetical kappa myeloma patient. Unfortunately, his myeloma is IgG kappa, right? So, but now we're going to measure IgG kappa, part of the molecule, and IgG lambda. When you summarize two of them, you would get total IgG, which is totally different test. So by measuring kappa and lambda part of the molecule, doctors get a little bit more in-depth information, especially important for tumor burden. And today, when you go and talk to your doctor about, have you ever heard about Hevylite? Serum free light chain assay could be applied to almost any myeloma patient in terms of measuring. If patient is producing light chains, you can measure them, right? When we're talking about the Hevylite, at the moment, Mayo Clinic recommends utility of Hevylite for IgA myelomas and specific type of IgA myelomas. If somebody's physician having a problem measuring that IgA myeloma, because it's on that, remember when we talked about that stream, about electric current separating those proteins, I showed you the perfect textbook picture where the peak was in gamma region, but with the IgA myelomas, they could be hidden behind those smaller peak on the front of that graph that I showed you. Think about it. You are in Nashville, North Carolina, and you're on the top of the hill, looking, the sunset. You can have very big mountain in front of you, and you can have 3 small mountains behind, but you won't be able to see them because the big guy is in front of you, right? So when on that graph, if this IgA myeloma is producing a very small peak, and then peak is hidden behind the other protein, it's very tough to observe them. So, message to remember and to take home or to your doctor, if you or the loved one has IgA myeloma that is hard to quantify by serum protein electrophoresis, Mayo Clinic recommends utility for that one. And that's the end of the story. I don't want to talk to you, give you funny slides on the Hevylite. So, IgA myelomas that are hard to quantify with serum protein electrophoresis. And that being said, do we have more questions on the serum free light chain assay or maybe Hevylite? Go on.
Yeah. Suppose the kappa is in the normal range, but the ratio is a little bit above normal. And then the kappa goes up and the ratio actually goes down because the lambda went up. What does that tell you? It happens to be a case in my particular situation.
Mm-hmm. So, could you repeat that one? Because you said like kappa. I'm sorry, I was having a problem just.
The kappa, here I am over here. Hello.
Okay.
The kappa is still in the normal range, it goes up.
Right.
But the ratio goes down because the lambda went up. Now the ratio is a little bit out of the normal range. What does that show? In other words, here in the example you gave us,
right.
Once the kappa goes to 100, you said the ratio was be 20 to 1, but already we know there's a problem because kappa is 100 and 19.3 is normal. So that's already...
Yeah, absolutely.
So
you're right.
So that doesn't really change anything. But I'm asking a situation where the kappa may go up, but the ratio may not, or on the opposite, the ratio is above normal, but the kappa remains within the normal range. What does that tell you?
Well, let me tell you something. Remember when I told you, like first thing, let's back up on, you remember when I told you that kappa and lambda are usually very close by, right? In the healthy, normal population, right? So you said like, oh, if it goes to 100 or 50 and I measure kappa, yeah. But in the case of, renal problem, kappa can go to 50, but lambda going to be 50. Not because patient is having myeloma, it is because both of them go up, because patient is essentially, does not have output, so to speak. You see what I'm trying to say? In the case of infection, both of them going to go up. Ratio is important because usually tell us there is abnormality in the balance. And that is usually typical for monoclonal gammopathies, including myeloma. If somebody has highly abnormal ratio, usually it's myeloma, but it could be anything else that originates from the B cell. It could be CLL, etc. Usually, predominantly, it is myeloma. If ratio is slightly abnormal, we don't say somebody is having monoclonal gammopathy. We just say, hey, this guy should be observed. Like we have a lot of patients that they have almost like normal levels of protein, right, of both kappa and lambdas, but slight abnormality. And usually those are the patients with MGUS, monoclonal gammopathy of undetermined significance. We have like 3 levels. Like, I have something on my skin. I go to my dermatologist. He says, Rudi, it's nothing, right? But you have to watch yourself. Put a lot of sunscreen, right? Or he may say, you know what? This is not normal anymore, but it's not cancer. But if you expose that thing to the sun, it might turn to cancer, right? So something in between. So we have 3 levels: MGUS, smoldering myeloma, and then we have myeloma, right? Many people have MGUS for 30 years, and they will never turn to myeloma. And then we have people who have MGUS detected 6 months ago, and they turn to myeloma, right? That's why it's very important to measure some things. And how we do, it wouldn't be very practical if somebody is 86, he has MGUS, and then we start drilling his bone marrow every 3 months, right? I don't think that would be, it would be inhuman, right? So, but I'm thinking by measuring serum free light chain assay, serum electrophoresis, we can measure if those proteins start going up, right? If they're going up, then we say something's going on. Then we can make a scan, look if there are bone lesions. By introducing serum free light chain assay ratio, like we know, like smoldering myelomas, we didn't treat them before because we just had melphalan and prednisone 15, 20 years ago. Now we have hundreds of different therapies. And that's why they decided to treat, because of the side effects, 20 years ago. Because they used to treat, they put patients on a maintenance therapy after the treatment, and some people from myeloma start getting leukemias. And they said, like, this medication is bad, but now we have better medicine, right? Thank God. We just, as a gentleman said before me, we had, just recently at ASH, 3 new approved medicines. So that's why ratio of over 100 thinks, oh, this is aggressive kind of smoldering myeloma. We can treat this one. Any other question? And if you have more, sir, if you have any kind of like graph or your results that you would be, we can do it one-on-one later on as well. Or anybody else. If you have questions pertinent to information.
Yes, sir. Let me ask you a question. We got astute members of our support group, and they follow their light chains
right.
As best they can and constantly worry about their ratio. Considering that any 2 labs that might be doing the testing using the binding site equipment, what kind of delta do you find between test results?
That is a great question. It's absolutely a great question, especially for the state of Florida, because we have so many snowbirds, so to speak, people coming from New York, right? And then they spend like 3-4 months in wintertime, and they go from one laboratory to another, right? So let's say if hypothetical patient John Smith had the light chains of 200, right? And then he goes to Boca Raton, and his light chains go to 175, right? Usually, when we validate the test sites, not me, but the tech service, right? Because this is complex, what we are measuring. Because if we are measuring cholesterol, right? Cholesterol is same in this particular gentleman or this lady or mine. They are the same molecule. They're exactly the same. We are measuring the same thing, right? Light chains are part of, right? They are unique. The light chains, each patient has his unique light chain. It's like when you are watching lottery machine, right? Getting those, numbers. That's how they look the same. But each patient is unique because remember, they are part of intact immunoglobulin molecule, hypervariable regions. That's good for us because by that, our antibodies are potent way to defend our system because they can adapt in million, if not billion ways to, right? So, back to your question just quickly. So when they compare results in one hospital to another, they would like to see there is no more than 10% difference. But I want to tell you, very important for all of you, not because just of serum free light chain assay. There is something what is called biological and analytical variability. Biological variability is something, if you measure this particular patient, which is not, and he's not on the chemotherapy, you measure him for every day, for 20 days, the results gonna go up and down. But that's why we took that in calculation when we are monitoring patient, right? So that's why we say patient is stringent complete response because he has negative serum urine immunofixation and total normalization of kappa lambda ratio. That's why many people like to see that there is at least 50% of reduction, at least in 3 different measurements over a period of time. So like if you give somebody chemo, patient has like 200 and it goes to 190, it doesn't really mean a lot, right? But if it from 200 goes to 40, because we could say, no, that 200 to 190 or 185 maybe was just due to that difference in instrument in New York. But, problem is because we are not measuring also on the same instrument, right? You go to Best Buy, there's 20 different TVs. There are TVs for $1,000, TVs for $10,000, right? So the different instruments have their own little contribution why there is a slight changes. You know, but you are right. That's what we accept, 10% of difference between one instrument to another instrument. So, any other question?
Last one, I think, right here. Right here.
It is a very good question. The question was if it's FDA approved, right? It is FDA approved, and at the moment, it could be ordered by your physician. I think Mayo Clinic Medical Laboratories and LabCorp are both able to, to do this particular testing.
Rudi?
Yes.
Hi, I have two questions on your slide that says Hevylite may detect relapse earlier. Now, does it predict relapse or detect it? And you also say may, not will.
Yes, that's a good question, and you said right. As I said before, like Dr. Loniel said, like more instruments you have, like in plane. So, because when you go to patient support groups, like we are in smaller setting, like 15, 20 people, and we are talking, and then I remember once somebody said hey, Susan, what's your light chain? And like people try to compare, like we have cholesterol level, If I have 250 and you have 250, we are both in trouble, right? Because we can compare it. But as far as light chain, every human being is unique. You have to stick to your own results, to your own background. You can't compare to say like, oh, somebody's having 200, I'm doing much better than somebody on 1,000. It doesn't really mean. Hevylite, as Freelite, might predict earlier in some of the patients, not in all of the patients. That's why nobody says like, oh, use serum-free light chain assay. If I would say that because, binding site paid for this trip for me to come here to see you, I would be on the level of used car salesman. I'm not that, right? We have different methods to measure different biomarkers, right? Nobody's saying, this, thanks God, this is just addition. This is just additional test. Thank you very much for your attention. It was a great privilege. Thank you.